Okay, you guys are all set.
Hi, everybody. My name is Naima Robinson, and I am the stroke coordinator here at Aventure Hospital and Medical Center. Today's lecture, we're going to be talking about stroke awareness because May is Stroke Month, or Stroke Awareness Month. And the goals in this lecture is to be able to ensure that you can reduce your stroke risk by being able to recognize stroke symptoms and also being able to identify what are some of the risk factors for stroke. So we're going to go through some of those today, and if you have any questions for me, feel free to send them to my email or send them to Bianca, or you can also ask them in the lecture here today. So some stroke facts, I kind of like to start off with this just because a lot of people don't really know very many facts about stroke. So about 800,000 Americans suffer from stroke each year. It's one of the leading causes of death in the United States, and also one of the leading causes of adult disability in the United States. 80% of all strokes are preventable, and there are a lot of stroke survivors. Previously, before we had all of the advancements in medicine as we do, a lot of people were left disabled from stroke, and because we have a lot of different interventions that can be done, a lot of the brain can be saved. So I'm going to kind of go through that. So first off, what is a stroke? So a lot of people don't know what a stroke is. There's two different types. You have an ischemic stroke, and 87% of all strokes are considered ischemic. And when I say ischemic, I mean blockage. So we have vessels that bring blood to our brain, and if there's a blockage in that vessel, then that vessel won't be able to bring that blood to our brain. And our brain needs oxygen to be able to help us do our activities of daily living, right? Then you have hemorrhagic stroke, which is our bleeding type of stroke, and 13% of all strokes are hemorrhagic. And hemorrhagic strokes are when you have a vessel in the brain that has ruptured, and that causes blood to seep into the brain area, and the brain is very irritated by blood, right? So those patients can have seizures, and ischemic stroke and hemorrhagic stroke can present similarly, but have different outcomes based upon the time, is left. So when I say ischemic, I want you guys to remember blockage. And when I say hemorrhagic, I want you guys to remember bleeding, okay? There's also something that is considered a mini stroke, but it's not really a stroke. It's called a transient ischemic attack. And it's where you have the symptoms of stroke, however, they resolved after a certain amount of time, like maybe 30 minutes to an hour. And a transient ischemic attack is where you have that blockage that builds up in that vessel. However, your body says, oh no, there's a blockage, I need to get rid of it, and it gets rid of it. And then your symptoms resolve. The reason why we treat transient ischemic attack, or TIA, the same way as we treat stroke is because if you have a transient ischemic attack, it's kind of like a precursor to having a stroke. So we want to be able to identify why you had that transient ischemic attack and then provide you with preventionary methods to ensure you don't have a full-on stroke. So we treat them just the same. So yeah. I always love this slide, this human brain mapping slide. A lot of our community does not understand that without our brain, we can do nothing, right? So you can have a heart attack, but you can still think, blink, see. But if you have a stroke, you may not be able to do what you were capable of doing before. So if you look at this slide, you have different lobes to your brain. So you have frontal lobe, temporal lobe, brainstem, cerebellum, occipital lobe, and parietal lobe. And each lobe plays an integral part in what we do. So for example, if I have an injury, whether a stroke, traumatic brain injury, or whatever, to my parietal lobe, I'm going to have issues with speech, pain, and touch sensation. If I have a stroke in my frontal lobe, I'm going to have issues with concentration and judgment, problem solving, plan, and even personality. our personalities start from our brain, also from our parents, but from our brain as well. So, you know, it's important to understand that if you have any type of injury to your brain, a lot of things can change for you. So I really, really love this slide. It's just something to kind of show you how your brain works in different areas. I know that a lot of people have heard of left hemisphere versus right hemisphere, or left brain versus right brain. So you can have a stroke on the left side of your brain, you can have a stroke on the right side of your brain, you can have a stroke in the back of your brain, and it'll all affect you differently. So left brain or left thinking people are very good with spoken language, number skills, written language, reasoning, and scientific function. So if I was Albert Einstein and I had a stroke on the left side of my brain, I would have a lot of issues with a lot of the things I would do in my daily life, because Albert Einstein was a genius. And it would be a major disability for me. Because when we think about stroke, we don't only want to think about, oh, I can't move my arm, I can't move my leg. We want to think about how disabling it is for our patient population in the future, right? So if I'm a public speaker and I have a stroke on the left side of my brain, it would severely affect my income, because I wouldn't be able to do my job, right? So we always want to think about those things. And then thinking about the right hemisphere, you think about music, creative awareness, spatial awareness, and things like that. So if I was Picasso and I was trying to paint the Mozart, but I had a stroke on the right side of my brain, I would have a major disability in that. So you always want to think about right versus left versus back. And you also want to think about the disability that comes along with stroke. So what is stroke? Like I said, we have vessels that bring blood to our brain. And an ischemic stroke and a TIA is when a blood clot occludes that vessel and then no blood can get to that area of the brain. Then the hemorrhagic, which is the bleeding stroke, which is where a vessel ruptures and blood goes into the tissues of the brain. And this is just kind of like an illustration that shows you ischemic versus hemorrhagic, because it's two totally different disease processes, okay? Now we're going to talk a little bit about some stroke risk factors. It's very important for all of the community to really understand what are the risk factors for stroke, because all of us either have one or have had one, a risk factor that is, you know what I mean? So we're going to talk about the controllable medical and lifestyle risk factors. So things like high blood pressure is controllable because you can take a medication to bring down your blood pressure and you can monitor your blood pressure. So it's considered modifiable or controllable, right? Atrial fibrillation. So what is atrial fibrillation? Our heart beats lub-dub, lub-dub, lub-dub. And when the heart beats irregularly in this atrial fibrillation, it causes a higher propensity for the body to create clots in the heart that can go to the brain. Now, what do we do for atrial fibrillation? We start patients on blood thinners to thin their blood out just enough to ensure that they do not create clots that can create a stroke. So they may be on Coumadin, Xarelto, Eliquis, things like that to thin out their blood just enough. It is considered modifiable because you can take the medication to modify the disease process. You have high cholesterol, diabetes, tobacco use and smoking, alcohol use, physical inactivity, and obesity. So these are all things that are modifiable either by lifestyle changes or by medications to help reduce your risk for stroke. Then you have your uncontrollable risk factors. So age greater than 55 years or older, your stroke risk doubles. Gender, male greater than female at younger ages, because a lot of times at younger ages, men don't like to go to the doctor and see what's going on with them. And then at 40, they end up having a stroke because they didn't know they had high blood pressure and diabetes and high cholesterol. And that whole mixture of things kind of creates a stroke. Race does play a role in it as well because of food choices and things like that. So, and, propensity for the race to have certain comorbidities like, obesity or hypertension. Hypertension is a lot more prevalent in the African-American community than others. So always remember, African American, Hispanic, or Asian Pacific Islander. Those are where we're primarily seeing the majority of our strokes. Family history of stroke or TIA, that's really, really important, because just like we need to think about our family history in regards to, genomes and things like that, we need to think about what could have been passed down to me hereditarily, right? Not saying stroke can be passed down to you hereditarily, but the other risk factors for stroke can be passed down, like diabetes, high cholesterol, high blood pressure, things like that. And then another uncontrollable risk factor is previous stroke. So if you had a previous stroke and you don't take care of all of the secondary preventionary kind of things that we're educating you on, then you're at a higher likelihood of having another stroke later on in your life, or maybe not later on. Because in my role as a stroke coordinator, I've seen people have a stroke 1 week, don't take the medication or don't do what they're educated to do, and then the next week they have another stroke. So, it's really, really important to make sure that if you have had a previous stroke, you're doing all of the secondary preventionary things to ensure you don't have another one. So what we're going to go over today is be fast, because you really need to know the signs and symptoms of stroke. And this acronym here will help you be able to remember them, and will also help you to remember to be fast. So it used to be, for those of you who already know the FAST, it used to be FAST, but we added the BE to ensure that we were capturing posterior strokes, or strokes in the back of the brain. 20% of all strokes are considered posterior strokes, and they are very detrimental to people, because some people do pass away from them because they're very disabling. So we're going to start off with the B for be fast. B stands for balance. Sometimes you may get up and you feel dizzy, and you may feel like you're leaning towards one side, and that's a sign and symptom of stroke. It does not mean that you're having a stroke. It just means this is something that we see in some stroke patients when they're having a posterior stroke. So they stand up, they get nauseous because they're dizzy, and they're thinking, oh, I'm nauseous, but they're actually nauseous because they're dizzy. So that's a sign and symptom of stroke. You can also have headache or loss of balance. So with hemorrhagic stroke, or that bleeding stroke, a lot of patients describe something called a thunderclap headache. And it's like the worst headache you could have ever had in your life. That's not comparable to migraine. So migraine will never feel like this thunderclap headache, even though I know for some people migraines are bad, but it will never feel like this bad as a hemorrhagic or bleeding stroke headache. E stands for eyes. So I want to say this, anytime you have a stroke, you can have your symptoms on one side or the other. Sometimes you can have it on both, but normally it happens on one side or the other. So you can have blurry vision in the right eye or the left eye. You can have a complete loss of vision. You can have double vision, right? So it's very important for us to monitor our vision and see how clear things are. So that's another sign and symptom of stroke. F stands for face. You can have facial drooping in the mouth, in the nose, in the eye, and that's a sign and symptom of stroke. So a lot of times in the hospital, we ask patients to smile really big for us, close your eyes really tight, put your eyebrows up, because we're looking for symmetry. We're looking for both sides being equal. One stroke mimic, and when I say stroke mimic, meaning it looks like stroke, is Bell's palsy. So Bell's palsy usually affects the forehead, the eyes, the nose, and the lip. So that's a stroke mimic, because it looks like stroke, but it's actually not stroke. It's inflammation of a nerve that controls the muscles in that side of the face, right? But, either way, it's great to play it on the safe side, by calling 911, saying, hey, I don't know if my family member or my loved one or this person is having a stroke, or are they having a Bell's palsy attack, So just always remember, lip, nose, eye, you can have drooping, you can have asymmetry with stroke or Bell's palsy. So A stands for arms. We always say arms, but it's also arms and legs, right? So when patients come into the hospital who are presenting with signs and symptoms of stroke, we ask them to hold up their arms like they're holding up a pizza box, and we look for drift. We look for flaccidity where, you know, one arm or one leg is completely weaker than the other. We also test for hand grip strength in looking to see, you know, is one hand weaker than the other? You can have a stroke and sometimes only not be able to move your hand, you know? So we look for weakness in the arms and the legs as well. We look for decreased sensation, which is another one, because you can move your arms as much as you want, but one side can feel normal and then the other side can feel numb, or you don't feel sharp touch, or you don't feel pain or burning sensation. And you remember, if we go back to the previous slide and talking about the lobes of our brain, you can have decreased sensation because there's a stroke in a particular lobe of your brain, right? So we always, you know, do like a pinprick test where we test this side against this side. Does it feel the same all the way from the top of the toe, the top of the head to the tip of the toes? Because you don't only get numbness in the arms and the legs, you can get numbness in your face. And that's kind of bringing us into the speech, where S stands for speech, right? So you can have speech difficulties. You can have swallowing difficulties. So when I say speech difficulties, you may be talking to someone and you're saying, oh man, they're so confused. You may ask them a question like, hey, Judy, how was your day? And Judy says, purple, blue, raindrops, and sunshine, right? She didn't understand what you said, but she could speak. And that's considered receptive aphasia, where the person seems very confused, and it's because they're not understanding what you're saying, but they can speak, right? Then you have another type of aphasia or issue with speech where you could be asking, you know, hey, Bob, how's your day? And Bob can only put his thumb up and say, because he can't express himself, he can't speak. So that's called expressive aphasia, which is a very, very frustrating aphasia for a lot of our stroke population, because, you know, they have to use, you know, boards to point out to what they want. They have to write down everything they want to say, because they can't physically say what they want to say. Then you have something called global aphasia, which is where you can't speak and you can't understand. And, you know, that's the worst type of aphasia. You can also have some speech difficulties as far as slurring of speech, where it sounds like your tongue is very, very, very heavy. So when we're assessing our patients, we always ask them to say very hard syllable words like mama, tip top, 50-50, huckleberry, to see if they can say those words without having that heavy type of tongue. So that's as far as speech is concerned. And T stands for time. So we always want you guys to call 911. Do not bring your loved one into the hospital yourself. The reason why is because EMS or fire rescue has protocols and assessments that they use to be able to bring the patient to the right facility. That's number one. Number two is not all hospitals provide stroke care. Not all hospitals provide complex stroke care. So it's very important for you to call fire rescue, call 911, and have them come assess your loved one and be able to identify what type of facility they need to go to. Another reason why time is very important as opposed to just calling 911 is because what I need for everybody to know is that every 1 minute your brain is without oxygen, you lose 2 million neurons. And our brains are not like our skin where we get a scab and they, you know, you get the scab and then you just have a little scar. No, once that brain dies, it just dies. So we're thinking 1 minute, 2 million neurons, 60 minutes, 120 million neurons. So it's very important to call 911 as soon as possible. Don't sit and wait at home and say, oh, I'll get better, I'll feel better, because you could be losing neurons by the minute, okay? So going into just some other things that we kind of talked about, severe headache, trouble seeing in one or both eyes, dizziness, trouble walking, numbness, facial weakness, trouble speaking, and confusion. So this is kind of like the same thing what we went over. But what I want to talk about really quickly is another type of stroke, which is an ischemic stroke, but it's a very large stroke. It's called a large vessel occlusion. And you can have one or all of these things in a large vessel occlusion. And we're going to go over that shortly. I wanted to touch on complex migraines, because I remember I was talking to you about how it doesn't feel like a hemorrhagic stroke. And so there's something called complex migraines, and complex migraines can mimic stroke as well, right? So a complex migraine is a really, really, really horrible headache that creates neurological deficits. So you can have weakness, you can have numbness, you can have blurry vision, but it's not considered a stroke, right? So there's a lot more research going into complex migraines. And once that comes out, I'll be able to provide you with that maybe in a later lecture. So, of course, I can tell you what stroke is, but if you don't really see it, you don't understand it, right? So it's my left. So on the left-hand side, you have a normal brain. So this is what your brain looks like normally under CT imaging or CAT scan imaging, right? You see you have both sides which look equal. You have the gray matter, some white matter, and that white circle around is the bone of the brain, is the cranium, okay? So if you move over one, you see that there's an ischemic stroke or a blockage stroke. An ischemic stroke looks a little bit grayer on CAT scan. And if you look, I have it circled with red, all of that area is dead, right? So this patient has a very large stroke. Not all strokes are as big as this, but I wanted to be able to show how big of an impact stroke can have upon the brain. Then you have hemorrhagic stroke, which is the next one over, where you have the white inside of the brain, and white inside of the brain shows up on CAT scan as blood. So that's blood. So remember, our skull as an adult, it doesn't expand anymore. So if there's no space for the brain to swell, and if there's no space for that blood to go, that could be very detrimental to the patient, leading in severe disability or leading eventually in death. So when I was a nurse on the floor, I would always try to show my patients' loved ones these types of images, because I need for them to understand why their family member can't speak. Why can't they move, their arm? Why can't they answer me, So this is just a really good slide that kind of talks about that. So are there treatments for stroke? I talk about all the detrimental things that happen with stroke, but can we treat stroke? Yes, we can. Yes, we can, right? So for our ischemic stroke or our clot stroke, there's a medication called Alteplase or TPA. And TPA is a blood thinner on steroids. And it is something that we give to patients if they meet a particular criteria and they come within a certain window, which is about 4.5 hours from a last seen well or onset, they can get the medication. So when I say last seen well, if I left the house at 10 o'clock and my mother was fine at 10 o'clock, and then I come back home at 12 o'clock and now my mother can't speak, that means the last time I saw her normal was at 10 a.m., not 12, right? So from 10 a.m. to 11, 12, 1, 2, 2:30, she can't get that medication anymore. So that's why it's so important to call 911, bring the patient into the hospital, because this medication, I've seen it reverse symptoms like in 10 or 15 minutes. So it's very, very important for you to know that there are medications that can reverse ischemic stroke or blood clot stroke, but you have to meet a particular criteria, and you also have to come within a certain time frame. There's also something called thrombectomy. Here at Aventura, we administer Alteplase, and we also perform thrombectomy procedures. And it's where if a patient has a clot in a very big vessel, they go in through the groin and they pull the clot with a clot or stent retriever. And it's this picture here on the right-hand side where you see the stent retriever pulling the clot from the vessel. So that you have to meet a certain criteria for that to happen as well. And that's up to 24 hours. We'll go in and do a thrombectomy if there's not too much dead tissue in the brain. If we say, okay, this tissue is salvageable, we should go for it, then we definitely will make the decision, or the neurointerventionist will make the decision. Then with our hemorrhagic strokes or our bleeding strokes, there's a couple of things that can be done. Because bleeding strokes can be caused by high blood pressure. They can be caused by ruptured aneurysms, which create a subarachnoid hemorrhage, right? So if it's a vessel issue or an aneurysmal issue, which is where you have a ballooning out of the vessel, some providers will go in and they will put coil in that vessel, or they'll put a stent in that vessel to stop this ballooning portion from seeping blood, right? Or they'll put a clip. We don't really do very many clippings anymore. We usually do it just, streamlined through the biplane room where we do coilings or pipeline stents. Additionally, if it's a very large hemorrhagic stroke, they may take the bone outside of the head and allow the brain an opportunity to swell, right? Because remember, the bone is stopping the brain from swelling. So we may open that up and say, okay, here, let's give the brain some area to swell. And they also may remove the clot that's in the brain. They may put a tube out. So there's a lot of different interventions that happen with hemorrhagic stroke. So this is kind of like a case study. You have a 75-year-old woman with a history of atrial fibrillation, which is a risk factor for stroke, right? With a new onset of difficulty speaking, right side paralysis, and facial droop for 2 hours, right? So this imaging here is called an angio, right? And an angiogram is where we inject dye into the vessels to be able to light them up so we can see what areas are getting blood, right? So the side of the brain that we're looking at is the left side of the brain. And if you look in that circle, you'll see an arrow, right? And that arrow is showing you where the blockage is, because this is a before and after picture. So the blockage is in the left internal carotid artery, and you see that there's no blood flow to this whole area. So the interventionalist went in through the groin up into the brain and pulled the clot. And this picture on the right side, or my right, maybe your left or my right, is the after. So you see there's a whole slew of vessels that are perfused because they were able to remove that clot. So that's what thrombectomy is. When I said about large vessel occlusions, those are really, really big strokes, and they need to be intervened on quickly to ensure that a lot of brain is not killed because of the lack of oxygen. So I always think that this is just interesting because you have to be able to see what someone's talking about as far as the brain is concerned. And you know, I'm a visual kind of person. So is there recovery after stroke? Yes, there is. For our stroke patients here at Aventura Hospital, we do provide both inpatient and outpatient rehab therapy. And we start rehab therapy basically from day one, right? You get admitted to the hospital, we're gonna get you up out of bed, we're gonna start speech therapy, we're gonna have a swallow evaluation on you, we're going to be giving you some physical therapy exercises that can be done. And, you know, so 10% of stroke survivors recover almost completely with those mild non-disabling strokes, or if they got TPA. 25% recover with minor impairment. So some people have to kind of work through over the years on getting that strength up in their arm or getting that strength up in their leg. 40% experience moderate to severe impairments. 10% require either skilled care or long-term facility, and 15% shortly die. And that's usually with your really bad hemorrhagic strokes or your really bad ischemic strokes. One thing I really want everybody to know is that with stroke, recovery is lifelong. It's not something that, okay, I got out of the hospital, I'll be fine tomorrow. No. It's something that takes a long time to be able to get back to your activities of daily living. I had one stroke survivor I called him back one day because I do phone calls, and he was like, Naima, you know, I don't like the foods I used to like, and I don't feel like my personality is the same. And, you know, I kind of had to do some education in that part and saying, you know, it's going to be something that you're going to have to learn over time. So remember that stroke recovery happens over time, and it's not something that just happens immediately. And it's not recovery is not only something that the patient has to do, it's also the caregivers, because the caregivers for our stroke population really have to take on a big role, because some of the caregivers are taking care of stroke patients who are now kind of like infantile. They need help with turning and washing, brushing teeth, feeding, and they may be 50 years old, but because they had this stroke, you know, it puts a lot of the burden on the caregiver. So, you know, we never want to forget about the caregiver, and as well as the stroke patient. So stroke test here. So you have a 48-year-old patient with a history of hypertension. I got to move this little thing over here. History of hypertension, who develops a sudden onset of slurred speech while watching television in his home. His wife recognizes his abnormal speech and asks him what's wrong. She then realizes that the left side of his mouth seems to be drooping slightly when he tries to speak. So this is a picture of a stroke patient. And if you notice, the left side of his eyes and the left side of his mouth is drooping. He still has the creases in his forehead, which tells me that it's not Bell's palsy. But, you know, what do you notice that's different? He is facial droop. And according to the little paragraph here, he had some slurred speech. So if I was the healthcare provider, if I was the person at home, I would ask these particular questions. Can you smile for me? Can I see the symmetry in your mouth? And you'll notice that the left side of his mouth can't really, you know, turn up. And then, of course, I would ask, when did these symptoms start, right? So we need to know, when will the symptoms start? And then what should you do? If you see the symptoms, you should call 911, because time is brain. And we want to make sure we get the patient to, or her loved one to, whatever facility who can give the care that is required. Okay, so I always like to do a little test here. Next slide. All right, so can we prevent stroke? Of course. So what are some things you need to know? Know your blood pressure. Have physicals yearly. You know, check your blood work to see how your cholesterol is doing, to see how your hemoglobin A1C is doing. Find out if you have atrial fibrillation. If you have those yearly checkups, then you'll be able, your doctor can monitor for those things. If you smoke, stop smoking. Vaping, if you vape, stop vaping. If you drink alcohol, make sure you do it in moderation. Make sure that you're not, you know, drinking excessively, because what a lot of people don't know is our liver is what helps create those clotting factors, right? So if our liver can't create what we need to help our bodies clot, it puts us at risk for that bleeding stroke, right? For having a really bad bleeding stroke. Know your cholesterol number. Know if you're a diabetic. Make sure you're exercising at least 30 minutes a day, whether it's steady state cardio, which is considered walking, or whether it's high interval training. Make sure you're at least doing something to burn 250 to 500 calories extra from what you would normally burn, right? Make sure you're not eating too much sodium in your diet, because that helps increase your blood pressure. And also, if you experience any stroke-like symptoms, call 911, because every minute does matter. Because remember, every 1 minute you lose 2 million neurons and they don't come back. So always call 911. Don't wait and sit at home, because we could intervene if you come quicker. So I always end my presentation with a quote that the expert in anything was once a beginner. I want to thank you so much for your time. And if you have any questions, you can ask me them now, or you can send them to my email at naima.robinson@hcahealthcare.com. And I really, really do thank you for your time.